I'm Krista Phillips, and I'm the Community Education Coordinator with the Arthritis Society in New Brunswick. And I'm happy to have Dr. Alexa Smith here with us again this evening, and I'm just going to give a brief introduction of her work. Dr. Smith is originally from Halifax, Nova Scotia. She completed a Bachelor of Science with honors at Acadia University and then attended medical school at Dalhousie University. She did her general internal medicine residency training at the University of Ottawa and then returned to Halifax for her rheumatology fellowship at Dalhousie University. She completed her training and joined the Division of Rheumatology at Capital Health in July of 2013 and moved to the St. John Regional Hospital in January of this year and became an assistant professor at Dalhousie Medicine, New Brunswick. Dr. Smith is interested in inflammatory arthritis. In particular, she has an interest in the cardiovascular risk factors associated with rheumatoid arthritis and is part of a national group of rheumatologists investigating this. She's also very interested in medical education and is currently completing a master's in medical education. And as I just learned tonight, she's also responsible for the adolescent and adult clinic at the St. John Regional for adolescents and young adults with rheumatic illness. And that's the first of its kind in the province. It's a multidisciplinary team that comprises the clinic, and it's much needed. And so that's a very exciting development. And we have her to thank for that. So I just welcome Dr. Smith, and there will be time for questions at the end, but we are filming tonight so that we can make this presentation widely available through our website. So at the end, if you have questions, Dr. Smith will be happy to answer them, but she'll just repeat the questions so that it gets picked up. Thank you.
All right, thank you very much, Krista. I'd like to thank the Arthritis Society for inviting me to speak on gout. I picked gout as a topic because it's incredibly common and it's also very easy to treat, but I think the understanding of how we treat it really has been a bit confused over the years, and so I find a very satisfying disease to treat, but for the most part as a rheumatologist, I don't see people with gout. 9 out of 10 people with gout can be completely and perfectly managed by their family doctor, and I'm just going to give you some tips and some discussion on gout today. There'll be ample time for questions at the end, even though we did start a little bit late. So I have no relevant disclosures related to this talk or any medications that I'm going to talk about today. So the history of gout is a really neat thing if you ever look it up on the internet. It was once known as the disease of kings, and the reason was that you had to have a rich lifestyle and a rich diet in order to have gout. So of course, back in the 14 and 1500s, and really up until just the last century, if you weren't wealthy, your diet really was quite limited and quite minimal, and you weren't overweight, and you usually didn't have trouble like high cholesterol. Plus, you were probably working a physical job. So it was people like King Henry here who had gout. And what I find very interesting is if you go through old political cartoons, they would often, especially out of the British Parliament in the 1800s, would portray their rich lords and the aristocracy as being overweight, older men, and if you look carefully, one of the feet would usually be bandaged and put up on a footstool. And they were making fun of them for having gout. Sometimes you'll see them with a cane or leaning on a cane, so you can see that there in the bottom left. And I don't know if you can read it, but I found a great cartoon there on my left here. So it says, "It's enough to discourage a man. I've cut myself down to 4 meals a day and a bottle of brandy, and yet this infernal gout's as bad as ever." However, we know now gout in present day is the most common form of inflammatory arthritis. It affects up to 3% of Canadian adults, and that's probably about accurate for New Brunswick, 3%. The incidence has doubled over the last 20 years, and I have no doubt that we can attribute it to just the basic changes in diet, more processed foods, more fast foods, less fruits and vegetables. And when you look at, if you're on a tight budget, nowadays it's really the kind of things that don't spoil that people are ending up eating, which aren't really in our best interest for health and weight. Additionally, we've become less physically fit, we've lived longer, so there's a few other things as well. We know that it's more common as you age, and it's more common in men. In fact, women who are premenopausal, as a rule, do not get gout. There's a few exceptions if there's a strong family history with a genetic abnormality in the kidney, well, very rarely a woman might have gout, but really if that's the case and she's premenopausal, she needs to be seeing some specialists. However, I am seeing more and more men in their 20s and 30s presenting with their first or second attacks of gout. And that's something probably we wouldn't have seen 20 or 30 years ago. So what is gout? Well, it's typically characterized as acute, recurrent attacks of inflammatory arthritis. So inflammatory arthritis are episodes of red, hot, painful, swollen joints. The most common presentation is in a great toe, in that first knuckle of the great toe, and about 50% of people, that's how it will initially present. And we call that podagra. That's very classic, and essentially if that's how you present, that's the diagnosis, you have gout. However, it can really affect any joint, and certainly as the disease progresses, I've seen it in, well, you name the joint, and I've probably seen it, including even in the spine. So it's extraordinarily painful. This cartoon really depicts it. It's just an excruciating localized pain in one or two joints. However, it's more than just joint pain because it can cause a host of other problems, in particular recurrent kidney stones that can result in kidney damage, or kidney disease, completely unrelated to the stones, but from high levels of the uric acid that cause gout, which your doctor may refer to as a nephropathy, and tophi in the skin. So you can see here on your left some examples of tophi on the joints. And if you saw this in real life and touched it, it would be a little bit soft but relatively firm. If it were to get cut or banged open, a milky substance would come out. It wouldn't be quite fluid. It would be a little bit more of a goo typically. And there on your right is an example of tophi up and along the ears. There's a few other places, like over the elbows, that I look for tophi, but on the ear is one that I've picked up a couple times, and once I see that, the diagnosis is made. It's gout. So I took this slide from the internet, and I thought it really described kind of the general progression of gout very well. So initially, you may just have high levels of uric acid, which is what caused gout, but that doesn't cause any problems, and that could be for many years. And then you might have one flare, or one great toe that gets painful or swollen for 7, 10, or 14 days, and it could go away. It might even go away for a few years. In fact, I've had a few men come to see me, and they swear the episode I'm assessing them for is the first time they've ever had an attack. But when I go and check the records on the provincial healthcare system, I can see that there were x-rays done 4, 5, 6 years ago for a swollen, painful toe or foot. But over time, if it's not treated, it's going to come more frequently. The attacks are going to be more severe, they're going to last longer, and ultimately, over many years, it's going to become permanent. And it's not going to go away. And we refer to that as gouty arthritis, and that's the stage where you'll typically start seeing tophi develop. And they will grow and grow until we treat them. So what causes gout? So essentially, gout is an accumulation of uric acid, which is also called urate, in your blood system. And so your doctor may check your urate level and may comment on whether it's high or normal. High levels of uric acid will accumulate and form crystals in the joint. They can also form crystals in the kidneys, the skin, and elsewhere in the body and create quite a bit of havoc. These crystals will cause a local inflammatory response from the immune system. So essentially what happens is that the crystals hang out in a joint, like your toe or your ankle or your knee, and they don't really cause any problems. And then for some reason, maybe you get unwell, maybe you've started a new medicine, maybe you've twisted your knee, the crystals get all riled up and they start causing trouble, and your immune system says, well, these aren't supposed to be there. And they go in and start eating those crystals. And that's the inflammatory response that produces that redness, that heat, and that extraordinary pain that's associated with a gout flare. And you can see from this picture here, these crystals under a microscope, these would have been withdrawn from a joint using joint aspiration and then looked at under the microscope. And we'll do that often, and when I see the crystals, then I know, well, that's definitely gout causing those problems. So there's really two ways that you end up with elevated uric acid. The first is very uncommon. Less than 10% of cases of gout will be overproducers. So that means that they just create too much uric acid. That typically will run in families. It's almost always genetic, and it's diagnosed at an earlier age. The vast majority of people, 90% or more of gout cases, it's due to under-excreting of your uric acid. So the way you excrete your uric acid is through your kidneys and out the urine. And for whatever reason, you can have reduced filtration of the kidneys, whether that's from certain medications you're on, whether that's from other reasons that the kidneys might be damaged, or whether that's just from many, many years of accumulating uric acid that your kidneys can just no longer keep up. But essentially, the kidneys just can't filter the uric acid out at the rate that it needs to, and the uric acid builds up. So there's a few key dietary risk factors. Back a few decades ago, before we really had good treatment for gout, I think that there was a really strong focus on dietary intake. At this point, there's not as much evidence that being extraordinarily strict with your diet is going to make a big difference. Only about 12% of people is their gout solely related to their diet. That being said, having a healthy, well-balanced diet is obviously in everyone's best interest, and it's in the best interest of your joints for a multitude of reasons, preventing or reducing your attacks of gout being only one of them. But we know that regular or binge alcohol intake is a major factor for accumulation of uric acid and flares of gout. So in particular, beer is the really big culprit. It's not uncommon that I'll see a gentleman come in with a flare of gout, and he can relate it back to the weekend where they had a few too many beer at a barbecue or whatnot. Wine probably doesn't have that same effect. Some people argue one glass of red wine might be a little protective from a gout perspective. So it's not that you have to cut it out, but certainly avoiding beer would be an easy change in diet. The other big one is high sugared drinks. So that's really anything with fructose. So you have your pops, you have your juices, and then anything like corn syrupy, any sauces that you might use, or certain treats, especially processed treats, almost always have high levels of fructose in them, and cutting that out as well would be a key management. That really goes far beyond just being worried about gout, right? And then we know meat and seafood. I don't advocate cutting all meat and all seafood. If that's what you love and you want your feet of lobster in August, well, go ahead. Just make sure you have your pills on board or somewhere nearby. If you know what you're getting into, I think it's a reasonable decision. But certainly, everyday intake of red meats and certain types of shellfish and seafood can increase your risk of gout. But it's really the medical condition. So I'm not sure if people are familiar with the term metabolic syndrome. It's a tetrad of conditions. So these are people with abdominal obesity, high blood pressure, some insulin resistance or pre-diabetes or diabetes, and high cholesterol. So in this province, that accounts for a very large percent of our population. And having metabolic syndrome basically makes you a sitting duck for gout. And that's really multifactorial. But other reasons that might increase your risk for gout would be having an injured joint if you fractured an ankle joint previously, or a damaged joint, like the first knuckle in the foot is a common area to get regular wear and tear osteoarthritis. Well, that predisposes you to flares of gout as well. Having kidney disease, as I've already discussed, so your kidneys aren't filtrating as well as they should be. Having certain abnormal blood levels, so sometimes certain types of anemia, for example, can put you at risk for gout. Anyone with an organ transplant, so that's a little bit more rare, but they're a bit more complicated, and those are people that I'll often be involved with. Partly that's the medications they take, and partly just the status that they're in with their organ transplant. Some high blood pressure medications, in particular diuretics, can increase one's risk for gout. I don't recommend stopping a diuretic if you need it, but if you and your family physician are trying to figure out what's the right blood pressure medicine for you, and you don't specifically need a diuretic, then avoiding it if you've had a history of gout would certainly be reasonable. The other one is low-dose aspirin, so that's your baby aspirin a day. Obviously, if you need a baby aspirin, maybe you've had a heart attack or heart disease, you need to take it. We'll work around that, but that is a medicine that's been known to precipitate gout. And then any type of acute illness, trauma, surgery, hospitalization puts one's risk for a flare of gout up. It's very common that people come into hospital, maybe they've gotten dehydrated or had significant fluid shifts, or they've been unwell, started on new medicines, and then about 5 days in they get a flare of gout, and that's a very classic scenario that we might see. So how does your doctor diagnose gout? Well, a part of it's based on a history of recurrent, short-lived attacks of severe pain. This is 10 on 10 pain. It hurts just to have the bed sheet touching the foot at night. It's typically only 1 or 2 joints at the very beginning, but as I said, can accumulate over time. It often starts in the lower extremities. It doesn't have to be the big toe, but about 50% of people will present that way. And initially, it's short-lived. So it comes, it's horrible, and within 2 weeks, it's gone, and you're back to baseline. That's not the case 10 years down the road, but that's the first couple times. The physical exam, your doctor's going to look for a swollen, red, warm joint, and they're going to look for the tophi that we saw pictures of, so around the ear and the elbow. You'd have labs done, including for uric acid level and to see how your kidneys are functioning, maybe also to check cholesterol and your diabetes status. The key to diagnosis is a joint aspiration for crystals. So a big toe joint is quite difficult to aspirate. And in general, if it's a classic presentation of gout, we don't go trying to stick a needle into that tiny little joint. But if it's an ankle or a knee, those are easy joints to have aspirated, and it wouldn't be uncommon that that might be done in your family doctor's office or the emergency room. And that's where we look for those crystals like that picture you saw with the pink background and the yellow and blue crystals. If you've had a history of kidney stones, often the urologist or the emergency room doctor will ask you to collect a kidney stone, and we'll look at that under the microscope in the lab to see if it's uric acid crystals. And that would be another way we might diagnose gout, or at least symptomatic high levels of uric acid that need to be treated. And then you might get some x-rays. Initially, those x-rays should be normal, right? Like the x-rays on the left. So this could be a person who's had 1, 2, even 3 or so flares of gout, but in between they go right back to normal and they feel fine. That's a beautiful looking foot. But here on the right, you can see, and I don't know if I have a pointer here, hopefully I can bring it out, that this is actually being eaten away by a tophi. So you get almost like a Mickey Mouse ear punch out lesion in the bone, and that's from those tophi absorbing the bone, and that's irreversible. So that's one of the things that I want to see avoided by treating gout properly. Okay? Sometimes we can even see the tophi on x-ray. They're quite white and large, and that's another thing we might look at. All right, so you've been diagnosed with gout. Now what do you do? Well, there's really 2 lines of treatment. There's the acute treatment to stop the severe flare, make you feel better, and get you back to doing your daily activities. And then there's the chronic treatment. And that chronic treatment is really focused to reduce your recurrence, to prevent those joint erosions or bone erosions, to prevent kidney stones, and to prevent kidney damage. So for acute gout treatment, well, there's really 3 medications that we consider. There's anti-inflammatories, so those are things like ibuprofen, naproxen, indomethacin. You might know them as Advil or Motrin, Aleve, etc. And they certainly work well to reduce any types of swelling or pain. There's a drug called colchicine that I'll speak a little bit more about in a minute that's very commonly used for acute flares of gout. And then there's steroids that we use typically in more severe cases or complex cases. So anti-inflammatories are a good choice for any young, healthy individual. So if I have a 30-year-old gentleman who's on his first or second attack of gout, and he gets better with indomethacin in a week, well, that's a perfectly reasonable treatment at that time for an acute flare. However, they carry risks including bleeding in the stomach or ulcers. They can increase your blood pressure. They can increase your risk for heart attacks and can even worsen kidney disease. So for a lot of individuals, it's not a good choice. And maybe you might take 1 or 2 that night while you're waiting to see your doctor the next day, but it's not something you're going to take on a daily basis. But they do work well and they work quickly. So colchicine is a drug that we use almost solely for gout. It's actually derived from the meadow saffron flower. So a few years ago, there was a new regime that came out that was shown to be more effective. Colchicine was a drug that has been around for quite a few decades. And it used to be a medicine that your doctor would tell you to take, and take it every hour until you got diarrhea. That's not how we do it anymore. Although I'm not sure that we've completely got that message out, okay? The way we take it now is to take 2 tablets at the first twinge of gout. A lot of people will tell me they get an electric shock or a little itch in the joint. Well, I say hop out of bed and take 2 tablets. 1 hour later, you take 1 more tablet. When you wake up in the morning, there's a good chance, if you got it right away at the beginning, that that gout attack will be completely aborted. If it is not completely aborted and there's still some pain or a little bit of swelling or redness, then you should continue with 1 or 2 tablets of colchicine every day until it's gone. So what that means is that anyone who's had a history of gout, I think, should have a bottle of colchicine safely stored away in their medicine cabinet or somewhere where they know they can find it at the first onset of gout. Because if you have to wait 6 or 8 hours to get it filled at the drugstore, you might have missed the boat. Colchicine is a very well tolerated drug other than the diarrhea. And I actually think having the diarrhea as a side effect is a good thing, because all that means is you're taking a bit too much. So I don't ever have to worry about someone accidentally taking too much. They get diarrhea and they just cut it down by half. If you're taking 2 pills a day, take 1 pill a day. If you're taking 1, take half a pill a day. Take half a pill every second day or every third day. It's not an adverse event, it's not an allergy, it's just that's what that drug does when you're taking too much for your body. So I never have to worry about any serious things happening other than that, in most patients. We don't use it long term, so many, many months to years in patients, because there can be some side effects that build up over time. It's particularly seen in patients with severe kidney disease. And if you have really bad kidney disease, we wouldn't use colchicine at all. Those would be people who are severely limited by the kidneys, followed by a nephrologist. Maybe dialysis is in their future. We would just avoid the colchicine altogether in those patients. And I always like to say the important caveat that colchicine is extraordinarily poisonous if the entire bottle is taken at once. So children and animals, there's no antidote. It kills them very slowly over days to weeks, and it is terrible. So we have a family friend, he has gout, and I go to his house, and he has the colchicine sitting on his table next to his turkey sandwich, and he has 1 cat and 2 dogs. And it drives me crazy, because it would be so easy for one of his animals to just wolf down the pills. And there would be nothing that one could do, essentially, if you caught it right away, but after an hour even, it would be horrendous. So it's something that is very safe for you if you're taking 1 or 2, 3 pills a day. You're not going to have any side effects other than diarrhea. But if you have someone who wouldn't know better and they took the whole bottle, then that could be quite bad, especially smaller individuals, kids and pets. The third option for acute treatment is steroids. So oral prednisone is used in severe multi-joint attacks or when other drugs are contraindicated. So maybe in those patients with really bad kidneys and they can't go on anti-inflammatories and they can't go on colchicine, you might see steroids used then. There are a lot of side effects associated with prednisone, right? I'm not going to go over all of them tonight, but they increase your blood pressure and your sugar and make you feel anxious, make you hungry, make you gain weight, thin your bones. I mean, the list goes on and on. So for gout, we typically try to avoid it, but we have a few people out there who get these horrible attacks and, both feet and a hand, and it's just, impossible to manage. Well, then a medium dose of prednisone for a week would be reasonable. Where steroids would be the perfect treatment option is joint injections. So we put it right into the joint. So if your knee or your ankle's flaring, well, a localized injection has virtually no systemic side effects. And it can reduce that swelling in 24 to 48 hours. So that's a great time to consider a steroid injection. So acute gout treatment. In the early stages, gout is extraordinarily satisfying to treat. You can imagine that if you get a swollen joint on Sunday and you see your family doctor on Monday or Tuesday and the doctor calls me and says, I really think they need an injection, and I squeeze you in on Thursday and I inject you. Well, no matter what, you're actually going to probably be better by Saturday or Sunday, and you're going to think it's all me. So I get a lot of satisfaction treating gout. No matter what at the beginning, it settles very easily. However, over time, attacks become more frequent, they last longer, and they're much more difficult to treat. So at the end of the day, usually by the time I see a patient, the key is just to be very stubborn. Gout is very stubborn. It's something that's built up since people were born, 10 years old, 20 years old. So we have a lot of years to undo. And so nothing works in those chronic phase of gout very quickly. But not treating is dangerous because you may develop chronic tophi, joint disease, amongst other problems. So your chronic treatment of gout. So who needs chronic daily treatment of gout? Usually those are people who have frequent disabling attacks of gout, and that definition is a bit fluid. Some people say it's 2 attacks a year, some people say it's 3 attacks a year. If you have 1 attack in multiple joints, the kind of attack that might land you in hospital, well, that's probably enough. So it really depends on the patient. But a few attacks in 1 year certainly qualifies, so that's a lot of people out there. If you have any tophi on physical exam or erosions on x-rays, if you have kidney disease already or recurrent uric acid stones, those are people who qualify for chronic gout treatment. And the key with chronic gout treatment is to lower your uric acid. So a caveat has to be that you need to have an elevated uric acid. Now, your doctor might check your uric acid during a flare of gout, and it might be normal. It might be 360 or less. It's a funny thing. Once that attack settles and you're feeling 100%, your doctor will ask you to go and get a blood test again for your uric acid. And at that point, when you're feeling great, your uric acid will be elevated. So we know during attacks it drops temporarily. I like to tell people it's because all the crystals go into the joint to cause problems. I don't think that's really the physiologic response, but it's a good way of thinking of it. And then when things settle, it's because it's all dispersed all through the bloodstream again. So the key medication that we use for chronic gout treatment, they're called xanthine oxidase inhibitors. So you might have heard of them as allopurinol or febuxostat. Febuxostat's trade name is Uloric, and it's the newest gout medicine that we have out there. So these drugs reduce the synthesis or the production of uric acid. Usually your doctor will start you on a 100 milligram tablet a day, and you'll slowly titrate that up. You'll probably be told to increase it by a pill every 2 to 4 weeks, checking your uric acid level in between. Once your uric acid level gets below 360, you've found your dose, and then you have to stay on it. Side effects to allopurinol and Uloric can include GI upset, a flare of gout, which I'll talk a little bit more about in a minute, as well as an allergic reaction. So this allergic reaction can be severe. If you start particularly allopurinol and you get a new rash, you have to stop it immediately and let your doctor know. If the rash is widespread or on any mucous membranes, you have to go to the emergency room. It is extraordinarily rare. So far, knock on wood, I haven't had any patients develop this rash, but it can be life-threatening. It's almost like a burn that might need fluid and admission and medications. But it's very important, new rash, stop the allopurinol, and you never take it again. So here's a couple pictures just to give you an idea, not to frighten you. I debated putting the photos in, but I always have these patients that call me and tell me they've had a rash to a medicine, but they don't tell me if they've stopped the medicine or not, and it's, one of the most frightening things. So it's very rare, but it is important to know about. So these drugs, the interesting phenomenon with allopurinol and Uloric is that anytime you start it or stop it or increase the dose or forget to take your medicine, you can get a flare of gout. Okay, that's very well known in the literature. So if this happens, it's really important to not stop the drug. So we know if I put you on allopurinol, you might have a flare the next day or the next week in there, but you don't stop it, you just get through it. So a lot of the time, we'll put you on another medicine, a prophylactic agent, such as the anti-inflammatories colchicine or low-dose prednisone. And that's meant to kind of lessen the flare or maybe even prevent a flare. That's not forever, but as we're adjusting the dose and getting your level to where it needs to be, you might be on a prophylactic agent as well. Some people say you shouldn't start these drugs during a flare of gout. That's probably not so important anymore. And the way I look at it is, well, anyone who I see is probably having a very severe flare of gout. So they're probably already on steroids. Well, if you're already on the prednisone, now's the time to start this other medicine because you're well controlled. You're not going to have any worsening of your symptoms. But there is debate, and if people would prefer to wait until their flare settles, or let's say your daughter's going to get married this Saturday, well, I probably wouldn't start the allopurinol tonight. Right? It's something that's trying to undo many years of buildup, and it's not an emergency to start, but it's very important to get started. The other misconception about allopurinol is that it's hard on the kidneys. It is possible you could have an allergic reaction. You could have an allergic reaction in your kidneys. That's extraordinarily rare. It is nowhere near as hard on the kidneys as having high uric acid levels and kidney stones and flares of gout and taking anti-inflammatories. So it really, if you have mild to moderate kidney disease, it's not a contraindication by any means to go on allopurinol. It does mean that you have to follow your kidney function on a regular basis, only because if the kidney function were to get worse, well then you probably need to reduce the dose. You don't need as much anymore, right? And then the last thing to remember about these drugs is they're essentially lifelong therapy. I tell everyone they're lifelong. You know, if your uric acid level gets to a good state, you've controlled your blood pressure, your cholesterol, your sugars, you've lost weight, you're active. Over time, we have some people who do taper down or taper off, but for the most part, once we start it, it's a commitment to stay on it indefinitely. A second-line therapy you may have heard of, they're called uricose-uric agents. So probenecid, it's been around for a long time. I think it might have been the first chronic drug for gout. We don't use it as much anymore, but it does promote the excretion of uric acid from the kidneys. The main thing to know about it is if you've had kidney stones with uric acid in them, we don't use this drug. But it's certainly a good option, and for some people who get the rash to the allopurinol, it's a great option to go to. And I mention that because Uloric, although it works wonderfully, is expensive and is not covered under provincial plans. I actually don't know exactly how much it costs. I can't give you a number. I know Costco has the cheapest drugs out there. But if you have a private plan, it's an easy one to get filled. But if you're on the provincial plan, it takes quite a bit of work to get you on it. And really, it's supposed to only be for people who've had that bad rash to the allopurinol. So there's a few lifestyle management things that you might be interested in knowing about that definitely have been shown to reduce the severity and frequency of gout flares. Weight loss and exercise and low-calorie diet, well, those are probably three things that we could all incorporate into our lives. So it certainly goes for gout, but it goes for almost everyone else as well. But that can change the severity of the attacks. Reducing alcohol, cutting out beer absolutely makes a difference. Increasing low-fat dairy, so skim milk, a glass of skim milk, or low-fat yogurt or cottage cheese might be protective. And everyone asked me about cherries. I guess the word's getting out there. So cherries have been shown to reduce uric acid levels. I am not sure they've been shown to reduce your actual flares and attacks of gout, but the way I see it is if you're doing everything you can for gout and you're still having flares and you don't hate cherries, I think that there's really no risk to them. So fresh cherries, frozen cherries, cherry extract, as long as there's no fructose or corn syrup in the extract, all great options. So go nuts with that one. Coffee, interestingly, has been shown to reduce your attacks of gout. Tea does not have the same benefits, so we don't know really where that's coming from. And maybe vitamin C. So I feel about vitamin C the same way I feel about cherries. There's really no side effects to taking a couple of tablets of vitamin C. Give it a try. You know, if it's just one too many tablets to put into the mix, it's probably not going to make or break your gout treatment. But these are some, for the most part, great lifestyle management recommendations that we all should be following anyway. And if it helps to reduce your flares of gout, I think that is, they're all very worthwhile. Great, thank you for coming.
Thanks.